Well, hello everyone. Welcome to the National Ovarian Cancer Coalition's Ask the Expert Facebook Live series, where today we will be dedicating to shedding some light on some of the advancements in the fight against ovarian cancer as we do every year at the end of the year. And over the next hour or so, actually, sorry about that, 30 minutes or so, we don't have an hour, but over the next 30 minutes or so, we'll aim to have a better understanding of some of this movement related to this complex disease. So, these advancements that we're going to be talking about aren't just scientific, but they really bring hope to those who are impacted by this disease, hopefully offering new possibilities in the future for treatment and care. So our focus will be on several key areas this evening where we've seen some movement and progress over the last year or two, and including updated risk guidelines, the evolving landscape of PARP inhibitors, and the promising developments in the realm of immunotherapy. So today we have two of NOCC's medical and scientific advisory board members offering their expertise with us this evening. We have Dr. Michael Bookman, Director of Gynecologic Oncology at Kaiser Permanente in Northern California. Thank you, Dr. Bookman, for being with us. And we also have Dr. Debra Richardson, who is the Associate Professor in Chief in the Division of Gynecologic Oncology at the Stevenson Cancer Center at the University of Oklahoma. Thank you, Dr. Richardson, for being here. Wonderful. So we're going to get started. Again, I want to thank you both for being here. I know that there's a lot of hope, hopeful and progress that's being made there in the field of ovarian cancer. And so one of the first topics that I would like to bring up is ovarian cancer risk reduction. As we know, or for those of you that don't know that are seeing this program, there are no recommended regular tests for ovarian cancer if you're at an average risk, because the tests, really aren't good at finding cancer early. And even for those at higher risk, these tests have not really proven to save lives. So right now we don't have screening for ovarian cancer. And so instead, what is now often suggested sometimes are surgeries to potentially lower the risk, like removing ovaries and removing fallopian tubes. So I'm going to have Dr. Richardson and Dr. Bookman talk about maybe some of the newer evidence that's been talked about really heavily in the media, specifically this past year, about a procedure called opportunistic salpingectomy, which could be an option for those at average risk for ovarian cancer. Could I open it up to one of or either of you to kind of maybe define what opportunistic salpingectomy is and what the option includes, and how that's a benefit to patients?
Sure. Thanks, Jennifer. I'm happy to start with that. So I have done opportunistic salpingectomies. What this means is that somebody's going to the operating room for already a planned gynecologic procedure, and it means removing the fallopian tubes at that same time. The most common is going to be when a woman is undergoing hysterectomy for benign conditions, which is one of the most commonly done major surgeries in the United States. And so in the past, if we were preserving ovaries, we would also leave the fallopian tubes. And actually, our colleagues in Canada, we have them to thank for this. They kind of brainstormed this back in 2010 and thought, how can we reduce the risk of patients developing ovarian cancer? You might say, well, why does that work, taking out fallopian tubes when the cancer's in the ovary? Well, actually, probably a lot of what we call ovarian cancer, and the most common is going to be high-grade serous ovarian cancer, actually starts in the fallopian tube. There is possibly some high-grade serous ovarian cancer that starts in the ovary, but we could never find a precursor, in other words, a pre-invasive lesion in the ovary that led to high-grade serous ovary cancer. And how we figured this out kind of is when pathologists were doing the special sectioning for patients who are at high risk, so patients who have, say, BRCA1 or BRCA2, they serial sectioned the fallopian tube, and they were finding precursors to what we called high-grade serous ovarian cancer. So that led to the idea that perhaps we could remove fallopian tubes and drop the risk of ovarian cancer. That's actually been shown now. So the same group that started this back in 2010 published a really nice article. Now it's in 2022, but there's been a few articles. But, what's nice is in British Columbia, every patient they can keep a track of because they have socialized medicine. So they basically made two cohorts. One patient a group of patients that were undergoing hysterectomy without the fallopian tubes being removed, and the other one with the opportunistic self-injectomy. And what they showed was that they, in fact, did decrease the risk of ovarian cancer in those patients. There were no high-grade serous ovarian cancers diagnosed in the group that had their fallopian tubes removed at the time of hysterectomy, or what we call opportunistic self-injectomy. So it also seemed to reduce some of the other types of epithelial ovarian cancer. And that was important that they used the proper control group, because we know actually doing a hysterectomy can remove reduce your risk of ovarian cancer, and actually so can a tubal ligation. So the most two common times you're going to see an opportunistic self-injectomy is at the time of hysterectomy, again, for benign reasons, or when patients are done childbearing and want to do a permanent sterilization procedure. For the most part, rather than having a tubal ligation, people are having their fallopian tubes removed.
Mm-hmm. Thanks for explaining that. It's very helpful. Yeah. And so this is just really a great option,
if I can
right?
just extend
Please.
that a little bit. So as Dr. Richardson said, most of the tumors that we define as ovarian cancer are really tumors involving the ovary. They did not necessarily originate in the ovary. And this is really very fascinating. It's just because of the hormones, the angiogenesis, the ovulatory process, cyst formation, a lot of things that take place in the ovary, which is a fairly complex organ, make for a good environment for tumors to grow. So cells can fall off the fallopian tube and implant on the surface of the ovary and then lead to these serous tumors. Endometrial cells from the uterus in women, particularly with endometriosis, can implant on the ovary and lead to endometrioid tumors, which we know are identical to endometrial cancer at a molecular level. And mucinous tumors are often due to tumors that originated elsewhere and implanted on the ovary at least half the time. And clear cell tumors also arise usually from endometrioid tumors and, again, implanted on the ovary. So it's kind of a very unusual situation. We don't find this in other parts of the body. And I think that it really does explain a lot of the biology that we've been struggling with over the years, much better than what I was taught 30 years ago, that the mammalian epithelium magically transformed into all these different tumor types. So I think it's really a very interesting thing that has important implications for our patients. And it's going to change the way we go forward and manage these diseases.
For sure. Yeah, that's very interesting. I was going to ask another question here related to this topic how do you typically discuss the option of having an opportunistic self-injectomy with your patients, and what are those key points that maybe some should consider when they're looking to do this procedure? Are there some things that might make someone ineligible for the procedure or less suitable for the procedure? Just curious maybe how that conversation goes.
I think that conversation is probably different when you're seeing a GYN oncologist than when you're seeing a general gynecologist, where a lot of these procedures are actually done by general gynecologists or, minimally invasive, for example. Now, I do these because there are patients I operate on occasionally who do not have cancer. We suspect that it's not cancer, et cetera. And so when I have a patient that I'm going to do ovarian preservation with, which that's in general patients who do not have cancer and are not at high risk of ovarian cancer, and I'm going to be removing their uterus and they're premenopausal, then I'm going to preserve their ovaries. But in general, I remove the fallopian tubes always when I'm taking out the uterus. There's not a lot of benefit to leaving the fallopian tubes behind. The times which might be contraindicated would be if, for example, if somebody's having a vaginal hysterectomy, which is the preferred route of hysterectomy for benign disease when it can be done, then it may or may not be accessible, and it's recommended not to change route of hysterectomy to remove fallopian tubes. Now, that doesn't mean that you can't have fallopian tubes removed at the time of a vaginal hysterectomy. You can, but sometimes that anatomy is a little bit more challenging, and so sometimes a fallopian tube or two might be left behind during a vag hyst. Or if somebody had significant scar tissue from previous surgeries or infections or something like that, where it's dangerous, there might be bowel stuff or something like that. In those cases, you would probably do that. But in general, most patients, when they're having a hysterectomy, are going to be able to have their fallopian tubes removed, and if it's appropriate, to have their ovaries left behind.
Wonderful. Wonderful. Okay.
It doesn't really seem the data, sorry to interrupt you, but it doesn't really seem like, at least the data we have, there doesn't seem to be any increased risk from this procedure at the time of other, procedures. So people aren't just going to the operating room and having their fallopian tubes removed for no indication. They're already going to the operating room and then removing the fallopian tube. And so that does not appear to increase any surgical risk.
And there is
Okay.
a trial currently ongoing through NRG Oncology, sponsored by the National Cancer Institute and also in Canada, looking at the long-term outcomes for women who have salpingectomy versus women who have salpingectomy with oophorectomy, removal of the ovaries as well, to see if really the reduction in risk is the same with or without removing the ovaries. And that's going to take a long time before we have data from that study, given but this is being done in higher risk population with BRCA mutations. So that will bring us the information more quickly and hopefully translate that to general population.
Oh, good. Great. Yeah. We did have one question that came through related to this. If you remove the tubes and ovaries, is there still a risk for primary peritoneal cancer?
Yeah, well, so yeah, because if there's endometriosis, that can lead to, as I said earlier, an endometrioid type tumor, or whatever might have been going on in the fallopian tube at the time may have already led to some cells being dispersed into the abdominal cavity, and they might not be cancerous or invasive at this point in time, but over a period of years, if they get additional mutations or other things happen, they might become invasive. So you're never going to eliminate 100% of the risk for a variety of reasons. And but at least we know in the patients with high risk for cancer with BRCA mutations that doing surgery brings reduction in risk down over 90%. So I think, our hope is high that this might benefit some patients, but it's also important to remember that ovarian cancer, while not a rare disease, is not as common as many other cancers like breast and lung, colon cancer. And so sometimes there's a sense that there's a tendency to overestimate your personal risk, but these are issues that hopefully will be worked out in the future as we go along.
True. Well, in closing of this particular topic, I think you both kind of wrapped it up nicely. Is there any kind of last thoughts or last comments you might want to kind of say about this procedure being done, or wrap it up? Or
I'll just say one more thing about it, which is actually
of course
exciting. We're actually thinking about trying to see, can we do opportunistic salpingectomy at the time of other benign surgeries, for example, gallbladder surgery. So today that's not done. And I don't want to get into all the logistics, but on the horizon might be that you go in for your gallbladder and you have your fallopian tubes done, you removed at the same time if you are done childbearing, obviously. So to potentially come in the future.
Okay.
I think you should just take the ovaries out and move them up into the chest, and then they don't get exposed to any of these cells.
Oh, goodness. Okay, wonderful. Well, thank you guys for elaborating on that topic. I wanted to move on now to treatment for ovarian cancer. And one of the first questions I wanted to ask you both was, what unanswered questions do you think we still have in regards to frontline therapy, as far as, advancements and progress? Kind of a broad question.
Yeah, it is, and there's many different components just to frontline therapy. There's the neoadjuvant approach where we give chemo first, then do surgery, and then do more chemo, which is becoming very widely adopted across the world for a variety of reasons, and seems to, in most cases, be equally effective and safe compared to doing doing surgery first. But there's still some debate about that, and we're waiting for results from what's called the TRUST trial, which is comparing aggressive primary surgery, including in some cases taking out the spleen or other areas that are higher up in the abdomen, and comparing that to the neoadjuvant approach where the surgery is done in the middle. And that trial has accrued, I think, almost 1,000 patients, but we're just waiting for the events to occur so it can be analyzed. And it's a broad international study, and that's probably one of the last big surgical trials that will be done in ovarian cancer therapy. So that's something we're waiting for.
Okay.
The chemotherapy backbone is not likely to change. I mean, I think that we all now recognize that platinum is an important drug, taxanes are important. There are also other drugs like gemcitabine and peg liposomal doxorubicin, et cetera. But But I think that, based on studies in over 30,000 women, we haven't found really a way to improve on the basic core platinum Taxol combination with some minor changes in schedule and dose. But that we're doing about as well as we're ever going to do with conventional chemo. So that's not actually being studied much at this point in time, although there are some newer drugs that might be tested in the frontline setting. Really, that's just the core backbone for most of the ongoing treatment and trials around the world. A lot of attention's been focused on maintenance therapy, and that's where the PARP inhibitors and other drugs come in. And that's a really interesting topic. The idea being, someone who's responded to initial treatment might then, by taking a medication like a PARP inhibitor, delay the recurrence of their disease or prevent recurrence of disease, but at the expense of, some chronic side effects. And how do you weigh these things? In my mind, the problem has been that we're kind of just, in many cases, offering this treatment to almost everyone. And yet perhaps only half of our patients might truly benefit from it, but we're not really good about determining at a molecular level and a clinical level who really should be getting maintenance therapy. So now we do have some tests that are very promising in terms of sensitivity to PARP inhibitors or resistance to PARP inhibitors that might allow us to really pick and say, well, this is not going to help you. There's no point in taking it and dealing with the side effects, or this could really help you, and it's important that you take it. Right now, we don't really have too many tools that help us do that other than looking for BRCA mutations. And so that'll be a big advance over the next few years. The other is the duration of therapy. That's not really been studied prospectively. It's been different in every study. Some women get PARP inhibitors for 2 years or 3 years, or it's been proposed maybe 1 year would be enough. And so we're hopefully going to do some studies to address that. It's just hard to get industry to support those trials. So we have to work in what we call a pragmatic setting, where we do simple studies with simple endpoints that aren't that expensive, and we can do them without industry support and try to address some of those important questions.
So, yeah, and then just to pick up off of what Dr. Bookman said, I mean, I think the holy grail is we want to cure more of our patients. And so the question is, how do we achieve that? And I think that for sure, platinum is not going away. There are some potential drugs that would like to potentially replace Taxol, but so far, nothing has beat Taxol as the second drug to combine with platinum. And so then we have the maintenance, as was mentioned. So we're looking at PARP inhibitors or bevacizumab, or a combination of PARP and Bev. And what I am finding very promising is that we are trying to get a little bit more sophisticated and not treat everybody the same way, and that we are trying to, think about what is their cell type, what's their grade. Because really what we're talking about here, when we're talking about this, is high-grade serous ovary cancer.
That's
if
right.
we wanted to switch gears a little bit, we could talk about low-grade serous ovary cancer, which is much less common. Okay. But in fact, we're wondering, do we need chemo at all for those patients? Can we give them hormones like we do for ER/PR positive breast cancer? And so we have a trial going on right now that's looking at carbotaxol followed by letrozole maintenance, which is an aromatase inhibitor, or letrozole alone and skip the chemo. And so that trial is
skip the chemo.
And so what I am excited about is that we're not lumping everybody together anymore, that we are thinking about some of these diseases differently. We think about clear cell, mucinous, low-grade serous very differently than we think about high-grade serous and high-grade endometrioid. And, then we have next generation sequencing tests, which are where we send the tumor off for testing to see what mutations does your particular tumor have, and we do hopefully germline testing where we're looking for germline where mutations people might have inherited. We don't know yet, but it's possible that PARP inhibitors actually will lead to more cure in BRCA patients. That does not appear to be the case for non-BRCA mutated patients, but at least from the SOLO-1 data, we're at about 8 years at this point. It'll probably be another year before we have the final overall survival data from that. But SOLO-1 took patients with BRCA mutations and gave them olaparib or placebo. And in that trial, not only do we extend how long before the cancer came back, overall survival has been improved. The question is, has cure been improved? And it's looking that way, but it's a little bit premature to declare that. So I hope that we've done that for BRCA patients, but obviously it's not everybody, right? So I think our goal is to eliminate people dying from these cancers.
Yes.
Yeah,
Yes.
I think that's really well stated, and it's just fascinating. If you look back over the last few
Yes.
years, the molecular advances that support these clinical trials and decisions, things that we just wouldn't even have thought about a few years ago. Like, for example,
Right.
30% of the women with BRCA mutations who eventually have tumors that become resistant to PARP inhibitors develop a second mutation on top of the original one that restores the function of the BRCA gene product. So it's like
Wow.
the tumor cells figure out how to fix the problem that made
Yep.
them sensitive to PARP inhibitors in the first place. And we never would have considered that to be a major issue, but it may be as many as 30% of these patients. That's how their tumors become resistant. And so we're also learning about HRD, or homologous recombination deficiency, as a marker to help select patients. But the current assays we have are not very predictive, because they don't tell you what's the HRD status today. They tell you what it was at the time of diagnosis, and it may have changed.
It may
So
have
we need
changed.
some
Yeah.
new assays, and people are busy working on those now. And I think within the next year or two, we'll have some much better predictors to guide treatment and hopefully get more people cured.
This is just fascinating. All of the inner workings of everything that we're learning and the progress that we're making, that I don't think, the general public really understand what goes on in this field. So it's very enlightening to hear you both talk about these things. One of the questions that just came through, you mentioned about PARP resistance. I wondered if I could ask, one of the questions that came in was, is it safe for someone to stay on PARP inhibitors indefinitely, or what is the timing on PARP inhibitors, and what about those who go back on them after they've
That's a
worked?
critical question.
Yeah.
There are still some patients from the original study 19 that was done in the UK with Jonathan Letterman and others, who are still on PARP inhibitors after now, I think, more than 10 years. And these were patients who had recurrent disease, went into remission with second-line treatment, then were placed on a PARP inhibitor. And so some patients have been on a PARP inhibitor for many years without recurrence. So those are situations where the BRCA mutation could not be repaired. And there are certain types of BRCA mutations where we know that they can't be mutated again to repair it. So that's more likely to be a durable long-term effect. Or there are other genes like RAD51C and D, BRIP1, PALB2, where the ability of the cell to repair the damage and become resistant may be less. So this is, again, the molecular stuff is over time giving us more information to help guide these decisions. But what I would really like to see is some randomized studies to address the duration of treatment, because all of these drugs do have some degree of toxicity, and we're often reducing doses and adjusting and managing the patients and so forth. If you could do just as well with 1 year of a PARP inhibitor instead of 3, that would benefit many people. And it's just hard to get, as I said earlier, hard to get the support to do those type of trials. But I think there are some ways we can do it.
Yeah.
To kind of go to add to what Dr. Bookman said, I also think it depends on what we're talking about upfront versus recurrence. For upfront, we have clear definitions. It's really 2 years or 3 years, depending which PARP inhibitor you're using. And the exception of that 2 years with olaparib was if they were not in remission, you could continue it past 2 years. So we have pretty
that's still not been proven to be the best way to do things. That's just the standard. Yeah.
Correct. Then for platinum sensitive recurrent, when they were getting maintenance, it was to progression or till toxicity or a patient wanted to stop.
Yeah.
I do think some of us are getting nervous about that idea, that may be too long. And, again, this kind of brings up, are some of these patients cured? For example, some of these patients that were on that study 19 where they BRCA patients and their cancer is never going to come back. And so then we're exposing them to a drug that they no longer need. The problem is we don't know, right? We
don't know.
All to say, who are you cured? Or are you not cured? And so there's some risk on both sides, both from the physician standpoint and the patient standpoint. In general, I am recommending to my patients, for the most part, to come off after 2 or 3 years after platinum sensitive maintenance as well. And it's really because of both some quality of life things, but also I'm concerned about long-term effect on the bone marrow. And while we know that myelodysplastic syndrome and AML are not common, the longer you seem to stay on them, that may increase those risks. And so I don't want to overstate them. They're not high. Okay. They're under 2%.
Yeah. It's really tricky because the longer you survive, the increased risk you have of having a secondary bone marrow problem, even without taking a PARP inhibitor.
Right.
So, we're helping people survive longer. That means they're also more at risk for some of these problems just because they're surviving. And we're often wrong. We think hard and carefully, and we try to design the best studies, but some of our hypotheses are not true. Like with bevacizumab, there was a large chorus of support to treat patients until they progress, rather than just treating for a year and a half or total duration as maintenance. And eventually a study was done comparing 15 months to 30 months, no difference whatsoever. And so I think that, we're so eager to try to help people. Sometimes we come up with these ideas, but we really have to test them. And that more prolonged therapy may not be better because it can encourage more resistance. And then if the tumor does recur, it's less likely to respond to these types of treatments. And on the other hand, if you stop, you can always restart it again. If somebody recurs 3 years down the road, you would have the option of putting them back on a PARP inhibitor or back on bevacizumab, for example.
So I think that's a plug for participating in clinical trials.
We just had a question that's very timely. Just had a question that came through of when should someone consider a clinical trial? And so, I would love to hear what you guys would say on that, because that's a good point.
I think every line of therapy, a clinical trial.
Yeah.
How I discuss this with patients is, help you look at the NCCN, which stands for the National Comprehensive Cancer Network. Those guidelines say, if you're eligible for a clinical trial, like we think clinical trial is the best way to treat it. Now, so I would point out that in pediatric cancers, 50 years ago, the majority of kids with cancer died. And today they have over an 85% 5-year survival. Most of those kids are cured. And why is that? Because 60% of kids with cancer go on clinical trial. In the United States, about 5% of adults with cancer go on clinical trial.
Right.
Well, more like 3%.
Progress if we don't have patients go on trial, and that it is multifactorial. But I just want to put a plug in for the National Ovarian Cancer Coalition having these funds to help support people, because sometimes there is some added expense out of pocket or whatever if you have to travel to a center, for example. So there is for those of you you can apply for a grant if you want a clinical trial. That's not I'm not trying to encourage you to go on a clinical trial so you get the grant, but I'm just saying so that to help offset costs.
Some of those costs, if that's a barrier for you, but clinical trials should be considered, I think, at every and every stage if possible. Absolutely, participate if you can.
Yeah, I think though we've got some challenges there because there's a lot of trials for recurrent disease, particularly platinum-resistant recurrent disease. There are not many frontline trials right now because there was an intense focus on integrating immunotherapy with chemotherapy, which turned out to be, again, much more complicated than we had anticipated. And so now there's kind of a little bit of a gap in the frontline trials. But I think we do have some opportunities to design some pragmatic studies, as I mentioned earlier, that at low cost could still answer a number of important questions that we have about frontline treatments.
Wonderful. Well, I'd like to, in the interest of time, move on to a next topic. And for those of you that are watching, I still encourage you to submit your questions, and we'll do the best that we can to address those either during the program as we're here tonight, or even after the program, we can get back to you with some of those answers. So keep those coming. But the next topic I'd like to kind of move into is another buzz topic for our community specifically is immunotherapy. And, we've been reading recently that the optimal treatment for patients with ovarian cancer also becomes really complex when someone considers the role of immunotherapy, which is almost like, to me, in my perspective, a new world in ovarian cancer, almost. I don't know. But could you speak to maybe some of the movement that we've seen with immunotherapy in regards to ovarian cancer, and maybe explain what immunotherapy is for those who may not know?
So immunotherapy is a big basket. I think a lot of people, when they're talking about immunotherapy, what they're talking about are checkpoint inhibitors, of which the best one, I'll start with the brand name because it's going to ring a bell for a lot of people, is Keytruda. What I would call pembrolizumab. So basically what happens is tumor cells secrete a substance called PD-L1, and your tumor cell, your immune cell, your T cell has a receptor. So we all have proteins on all of our cells, and this protein or receptor called PD-1, then it basically is communicating, don't kill me, I'm not foreign. Keytruda or pembrolizumab works by blocking that PD-1 receptor so that the tumor cell cannot communicate with it, hopefully then turning on the immune cell to recognize the cancer as foreign and kill it. That has not worked very well at all in ovary cancer.
Good to know.
Very well in melanoma, but not in all melanoma. For GYN cancers, I'd say we have far more success in uterine and cervix cancer than we do with immunotherapy in ovary cancer.
Okay.
This is a very hot topic right now in ovarian cancer. Yeah. We've had a lot of failures, but we haven't given up. But we think about tumors as cold tumors or hot tumors. And unfortunately, for the most part, ovarian cancer are cold tumors, and you need a tumor to be hot to be responsive to the immune cell. So this is where we get complicated trying to think about combos. How can we change the tumor microenvironment? So I think about tumors like cities. You know, a city has more things than buildings. You have to have streets. You got to have electricity. You have to have plumbing. So your tumor needs the same thing. It needs, you know, blood vessels to bring in nutrients and take away waste, etc. So you have to kind of play with the microenvironment to make ovarian cancer more susceptible to immunotherapy. So there's all sorts of different things being looked at right now. I would say it's all, for the most part, investigational. We do have, I think Dr. Bookman has alluded to, we've had some studies of immunotherapy in combo with carbotaxol, followed by either immunotherapy with PARP, and even including bevacizumab. So there is a couple of trials. We don't have any readouts on those trials really yet. There was one that has been presented, but the problem, I think in a lot of people's mind, is that trial is missing an arm. So it's not showing us what the benefit of the immunotherapy was. What it's kind of showing us is the benefit of the other things that we're given, which are already the things we're doing. Carbotaxol, PARP.
It's a common problem with these trials. That yeah, no, I think that's a great explanation. And I just would add, again, going back to where ovarian cancer comes from, that we've learned that the endometrioid type of ovarian cancer, which is identical to endometrial cancer, will frequently be something that can be targeted with immunotherapy, particularly if it's deficient in a DNA mismatch repair process or microsatellite instability. And then clear cell tumors, which also probably originate from the endometrium, are much more likely to respond to immunotherapy, particularly combinations such as the lenvatinib pembrolizumab combination, which has been used in endometrial cancer. So we're learning bits and pieces there, but in terms of the more common high-grade serous cancers, we do not know how to manage immunotherapy in that setting.
Yeah. Okay.
And then the other thing, I guess, to transition over with, so we don't get too long, is what are called antibody-drug conjugates, or ADCs. Some people think of that as
therapy, right?
Yeah, some people think of it as immunotherapy as well because they're using antibodies, but it's really,
right,
I guess, more accurately stated as a form of targeted therapy, just to be clear about that.
Yes, thank you. Yes, I was going to actually ask, moving into targeted therapies, I know that there's a lot being looked at, and one of the more common topics this year that's been talked about a lot is the new drug, as I would say, Ella here, because I can't pronounce mirvetuximab. Am I saying that right? I said it right. Mirvetuximab. So Ella here, knowing that, you know, could you maybe elaborate on maybe Ella here and what we're seeing with that with patients?
Yeah, I'm happy to start, and then Dr. Bookman can go. But you know, I should tell you that we treated the first patient in the world on that drug at our institution. My partner did, Dr. Moore, and she also ran a confirmatory trial. So that drug is now FDA approved.
Yes.
Really proud of that.
Yes.
It's a great drug. I've given it to a bunch of patients. It does have some side effects, but basically what it does, so I think about, so antibody-drug conjugate is made up of 3 parts. For one thing, again, like I said, all cells have proteins on them, and our cancer cells often have different proteins on the surface than our normal cells. And that's what the idea of an antibody-drug conjugate is trying to target something where it's going to be targeted to the tumor and not your normal cells, to try and reduce toxicity, like we see from regular systemic chemo. And so what Ella here, or mirvetuximab, goes after is the folate receptor, so folate, and about a third or so of high-grade serous ovarian cancer overexpress folate. And in order to know this, your tumor would be sent for testing to see if you have at least 75% expression or not, 2 positive or 3 positive. And that's just enough staining, okay, for the drug to take up. Then it has a linker to keep the drug stable in circulation while it's going through the body. And then it has ultra potent chemo. So it's still chemo. It's just smart chemo. Like I like to think about it like a smart bomb. Some people use the term Trojan horse, but basically the tumor cell takes it up, and then it gets cleaved in the side of the tumor cell, and then the drug is released. And how these drugs also work is there's something called the bystander effect. So what's great is not every cell in your tumor has to express it for it to kill some more of those tumor cells, because the chemotherapy has been released into the environment. For Elahere, some of the side effects that we talk about are ocular toxicity. We have some good mitigation strategies for that. So you do lubricating eye drops every day and for 30 days after you come off the drug. And then you do steroid eye drops for the first 8 days. It's 6 times a day the first 4 days, 4 times a day the next 4 days. Very important to kind of follow that eye toxicity guidelines. You have to see an eye care provider. It does not have to be an ophthalmologist. It can be an optometrist. And you do it baseline and then every other cycle up to 8 cycles. If you stay on for more than 8 cycles and you have not had eye toxicity, you don't need to keep doing that. It can cause inflammation in the lungs called pneumonitis, but quite frankly, I've probably only ever taken 1 patient off the drug because of that. It's usually asymptomatic and just seen on routine imaging. And a lot of people, I think, experience diarrhea. So we do recommend having some Imodium at home, and we can also prescribe medicines to help manage diarrhea. We can also dose reduce. And then I guess the last thing I would mention is, you know, that numbness, tingling neuropathy that can happen.
Yeah, so I can just pick up on a couple of points there. One is from a regulatory perspective, it currently has what we call accelerated approval, which means the approval is based on some smaller studies, and the large phase 3 trials, which are just now starting to report their data, will hopefully lead to full FDA approval, but we need to wait for the data to be analyzed and reviewed on that score. And there are a number of ADCs that are being developed right now, and they're all being handled a little bit differently. So some are being tested and looking for approval based on expression of the target antigen. Some are being looked at just in specific diseases. So Elahere in this case is, you know, specifically looking for targeting in ovarian cancer, but also now being evaluated in endometrial cancer, where there is high level expression of the folate receptor. And it's interesting that it seems to work better when you have very high level expression of folate receptor. And so there's a regulatory approved test using staining of the tumor tissue that most centers are doing now, through centralized laboratories, to see if there's enough staining to qualify for the FDA approved indication for the drug. Now, there are other ADCs, the best example being trastuzumab deruxtecan or Enhertu, which targets the HER2 protein, which is common in breast cancer, but is also found on probably 40% of ovarian cancers, but at low levels.
Oh.
And it's fascinating that unlike Elahere, Enhertu works even if the expression of the HER2 is low, like 1+, which would in breast cancer would be considered negative. In ovarian cancer, we call it low positive, and in endometrial cancer, the same. And it can work quite effectively even in tumors with 1+ expression of HER2, including tumors that are very difficult to treat, like carcinosarcomas. And that's been now published as a study from the Japanese Cancer Institute. So there's a drug that might actually get, it's currently approved in breast cancer and gastroesophageal cancers, but we're hoping that the approval will be extended to all tumors based on the HER2 expression, because it is active in many of those settings. And so, and then there are about 4 others that are undergoing very active investigation. Dr. Richardson has been involved with several of those already. And, you know, many of them are going to move forward, and they're quite impressive. And now using different chemo payloads. So the Enhertu uses a camptothecin analog related to topotecan or irinotecan, which we don't use that much in ovarian cancer anymore. So when you treat an ovarian cancer patient with a drug like Enhertu, the tumor cells are seeing a drug they've never seen before. So they're more likely to respond, and the response rates overall can be higher. So this is a very rapidly changing, very interesting field of investigation.
Exactly.
And I think it's going to have an impact not just in gynecologic cancers, but across the spectrum where these drugs are being used.
And that's the common theme here too. Oh, sorry. Go ahead, Dr. Richardson. Go
I
ahead.
was just going to say, just to kind of throw it out there, so mirvetuximab or Elahere is actually being looked at as maintenance in platinum sensitive patients who,
as maintenance.
Their tumors overexpress folate. You get, your chemo, so it's usually a carboplatin or platinum doublet, right? So 2 drugs, and then bevacizumab. You have to get bevacizumab with your chemo, and then you get randomized at the end of your chemo as long as you've had a response or stable disease to either bevacizumab alone or bevacizumab with mirvetuximab. So we are starting to see some of these ADCs potentially moving up in earlier lines of therapy as well, which is typically how we do drug development. We start in platinum resistant, and then we move it up maybe to platinum sensitive, and if we're doing really well, we might move it up to frontline.
Oh gosh, such progress. And I think the common theme here is time, right? It takes time to learn all of these things and to get these through to fruition and testing. And gosh, I want to thank you both for all that you do. We've covered a lot of topics here in a short time, but we are at that time. I really want to again thank you both for just covering the high levels of things that we've kind of had as hot topics this past year. I know that some questions are still coming through, and like I said, we'll do our best to answer those as much as we can after the program and kind of put those up somewhere for you to see. But yeah, any last comments as far as, wrapping up this year, maybe what you're excited about this next year in terms of progress being made in ovarian cancer, or maybe we've covered it all?
I'm just excited about my friends from NOCC in Tucson, Arizona, and I hope they're watching.
Yeah, hopefully Tucson is on.
Well,
wonderful.
I really enjoyed doing this with Dr. Bookman. I mean, he is an internationally known medical oncologist that has been devoted to GYN cancers and was the chair of our ovarian committee for our national cooperative group. So really instrumental in a lot of things that we've done for ovary cancer. So it's been a real honor. And I just hope we've answered some questions and given some hope. And the bottom line is we're not there yet, but we have devoted our careers to trying to make things better.
Very, very grateful. Well, thanks to both of you, and thank you for what you do. And until next time, we'll see you again.